Thank you so much, Emmy. My name is Julie Levin. I'm one of the pediatric chief residents, and I have the privilege of getting to introduce our grand round speaker today. Dr. Laurel Williams is an associate professor in the Menninger Department of Psychiatry and Behavioral Science at Baylor College of Medicine. Dr. Williams is the newly appointed medical director for the Centralized Operational Support Hub for the Texas Child Mental Health Care Consortium, coordinating the implementation of a statewide child psychiatry access network and telemental health to youth in schools. Dr. Williams is also division head and training director for child and adolescent psychiatry at Baylor. Dr. Williams completed both her fellowship and residency training at Baylor College of Medicine in 2004 upon graduation from the University of North Texas School of Osteopathic Medicine in 1999. She graduated with a BS in psychobiology and minor in fine arts at the University of Southern California in 1994. Dr. Williams has special expertise in working with youth who have suicidal and self-injurious behaviors and pregnant and postpartum adolescents. We've been looking forward to our presentation today entitled, A Call to Action, PCP Must Manage Mental Health. Thank you for teaching us today, Dr. Williams.
Well, I'm very excited to be here, and I'm excited to have this team assembled. It's a good Friday despite the rain, and I hope that we're going to share some really great information for everybody today. Let me get to my screen. So today, what we're talking about is a call to action. PCPs must manage mental health. I have an exclamation point here because I'm really hoping that by the end of this presentation today, I've really helped you understand why it's very important for primary care pediatricians to take this call, go to action, and help us manage mental health. So I have no financial conflicts of interest, but as a psychiatrist, I always like to joke I have plenty of psychic conflicts, but hopefully none of them will be on display today. I do want to thank Dr. Noon Tran. She is a developmental pediatrician for her contributions to this presentation. Dr. Tran is our Texas CPAN pediatric consultant and is a passionate advocate for children and their families. And so some of the presentation slides today you'll see were from her research on this topic. So the outline for the presentation today, we're going to talk about several things. I know this list seems really long, but I've actually practiced a few times, so I think we'll be able to get through it in the time allocated. We're going to first talk about the legislative win, and this actually fits really nicely with what we just heard about voting. Voting does matter, and we need you to be an informed voter and vote your conscience. But we also are going to discuss the percentage of youth with mental health disorders. Then we're going to review the allocation of child psychiatrists here in Texas. Next, we'll move on to the AAP, your own recommendations for pediatrician management of mild to moderate mental health disorders. Finally, we'll review some collaborative care models with the key characteristic about collaborative care, and then move into reviewing data regarding statewide collaborative care models that are out there outside of Texas. Finally, I'm going to describe the Texas Child Psychiatry Access Network itself, and then we'll have a brief audience participation that will actually utilize the 188-901 CPAN number. So again, I have several things to get through, but we're going to get through it. It's going to be fun. So the Texas Child Mental Health Care Consortium was born into being in 2019 because of passionate advocates who realized that we needed to do more for Texas children and adolescents when it relates to mental health. And so this program is about helping advance the healthcare quality of children across the state through interinstitutional collaboration, leveraging expertise of those institutions, nonprofit organizations, government agencies that are related to helping children and youth with mental health issues. And the vision for this consortium is a big one. It's Texas after all. We like to do things big. We have our vision statement say that all Texas children and adolescents will have improved mental outcomes. And that's really the goal that we're trying to do with this particular consortium. You can see that there's a website down there at the bottom if you want to go at some point and peruse it. I think you'll gather some additional good information. So of course, I've actually learned something in all this process. I actually learned many things, but one of the things is that you can have a law that's signed, but if there's no money attached to the law, then things cannot be implemented. So fortunately, they actually did, with a rider, put money into the bank for the consortium. And this is actually not out of healthcare dollar, it's actually out of general revenue. So what they did was set aside $49.5 million per year, so biennium, $100 million, to make sure that the aims and programs that are in the consortium can move forward. Now, we don't need $50 million to make the CPAN program run. There's actually 5 other initiatives that are within this consortium, but today I'm going to only be talking to you about the CPAN organization that we're developing. And I would like to say that the reason why it's general revenue funds is that we're not charging families for any of these services or any of these programs, and we're not charging primary care. So you can rest assured that by using these programs or recommending families to participate in some of them beyond the CPAN, that they're not going to be charged for the services. So I think that's another really big win for kids in our state. As I said, we came into being in August of 2019, essentially. We had several months to put together a plan. We had to turn it in by November of 2019 for the LBB to review it. And then they did approve the plan on January 16th, 2020. I think everybody knows that things take a little bit of time just generally when you're talking about academic institutions, but then COVID hit. And so there's been additional complications because of COVID, but nonetheless, we were able to get ourselves stood up. One of the things that the executive committee needed for the consortium was sort of a business team to lead it. And the University of Texas system was selected to do that process. But one thing that happened additionally was that they really understood, the consortium executive committee that I sit on understood that there's a lot of things that needed to happen that actually really require people that know mental health very well and can so make sure that these programs run from a medical mental health perspective. So they decided to create the centralized operations support hub. This has a central data management system. It did appoint a medical director, and Baylor, obviously, we applied for this role and we were successful, thankfully, in getting it. And so now that's why I have the title of medical director for the programs. There's several programs, but again, today we're just going to be talking about the CPAN program. So why am I telling you all this? Well, this is, again, back to this idea of voting. Voting matters. What we do with our society is very important. I can't stress this enough. I'm going to sit on the slide for a minute because I'm very passionate about this. I'm hoping that with my passion, I'm going to get you excited that you need to help us out with these problems. But there are youth in America that need everybody's help. 1 in 5 children have a mental health disorder. The NIMH actually estimates that 49% of all adolescents have had at least one time in their life a mental health disorder, of which 22% of those actually have a serious mental health disorder. But we know that 30 to 50% of children don't even get access to care. And we also know that mental health can affect a number of things within a young person's life: their physical health, their employment eventually, education, and relationships. We also know that depression and anxiety are the most common mental illnesses that are out there. And unfortunately, 90% of those who commit suicide, when they go back and do a sort of look back at the young person's life, they discover that they had an underlying mental health illness that if only somebody had been able to catch it and start helping treat, they wouldn't perhaps had attempted or completed suicide. I'm very passionate about this topic because I think it's actually a tragedy. It's a crisis in America that we're not really paying attention to for a number of reasons. Suicide is the second leading cause of death in young people in the United States. Let me say that again. If you hear nothing today, it is the second leading cause of death. And I would argue with you very strongly that it is almost completely a preventable death. We're talking about preventable deaths if only the young person was able to get access to care before they got to the point that they attempted suicide or completed suicide. As a pediatrician, you don't always know about it because unfortunately for many youth, the first time they try is the successful time. So this is where prevention and actually finding out what's going on with the young person before they even get suicidal is extremely important. It's a crisis, folks. When you look at the data around suicide, there was 50,000 suicides in the United States across all ages. Compare that to how many people had been killed through a homicide, which is about 20,000. I mean, we're up in arms, rightly so, when somebody dies by a homicide, but somehow we don't seem to have the same energy around helping prevent suicide. So I really want you to understand that you can be on the front lines helping and supporting youth and families with depression and anxiety and other mental health issues, and that can help alleviate this symptom of a serious mental illness that goes too far without getting treatment and in suicide. So when I look at these numbers, again, I'm going to break them down real quick. 10 to 14-year-olds, almost 600 people, children, die by suicide every year. The third leading cause of death is actually cancer, and that is 450. And then the fourth leading cause of death is with 172 is congenital issues. And then finally, number 5, it's 168 for homicide. And when they get into the age range of 15 to 24, the number of suicides is just astronomical. It's 6,000 15 to 24-year-olds who commit suicide. And then the third leading cause of death becomes homicide at that point. And then the fourth leading cause becomes cancer. And then the fifth leading cause becomes heart disease. So you can see that even at Texas Children's, we put a lot of really great work and energy into cancer, into heart disease, but potentially not as much energy as we could into preventing something. And again, part of that is because it's hidden to you. The young person doesn't come to the hospital because they've already ended their life. So please, we need to work together to really help young people not get to that point where things feel so hopeless that ending their life seems like the only choice. Why am I asking you this? Well, there's a really good reason why I'm asking you this. There's not enough child psychiatrists. There's not going to be enough child psychiatrists in the next decade. And this slide here from the American Academy of Child Psychiatry points out that Texas is in the red, like most of the actual country is, when it comes to the severe shortage of child mental health psychiatrists. Now, I'm talking psychiatrists today, but the same can also be held true for child psychologists as well as child therapists. There's not enough of us in the world right now to help. And so that's why we need to partner with other team members to really help address the gap. 80% of counties in the state of Texas have no child psychiatrist in that county. So I know right now most of you live in this area and you probably don't feel the pinch of not having a child psychiatrist, but even at Texas Children's, it can take months to get into our department because of the backlog. So even though we have more child psychiatrists in the sort of county, it still is not able to meet the volume that's there. So we need the help of pediatricians and PCPs to really turn the tide and really help provide care to children and their families. So once again, folks, pediatricians have to do so much. I say this with my heart filled with just happiness and joy that you're out there in the world. We need you to don your red cape and put on your mask. COVID, not COVID related, but superhero related. Keep that COVID mask on too. But we need primary care providers to come to the rescue. We need you to help us save the day because we're not going to save it. We're not saving it as it is right now. So that does mean task shifting, and we know that can be a difficult thing, but we want you to help promote mental wellness, not just looking for disease, but promoting mental wellness like you already do. Early identification, which is happening more and more. And then really that first line care. That's the piece that I think is still really missing, is that first line care. And what we hope will happen is with collaborative care models such as CPAN, you will start to have some ability to start doing that first line care that we're talking about today. So we know that this is going to mean that you're going to have to develop some additional clinical skills related to primary, secondary prevention, as well as assessment and treatment. But we don't want you to do this by yourself. We want this to be done within a collaborative environment, having a consultative relationship, and build a practice where team culture around that integrating of mental and emotional and behavioral and physical work all together. And I'm telling you something that actually is not something that a child psychiatrist has created, which I know sometimes is the worry that I'm trying to turn everybody into child psychiatrists. I'm not. It'd be nice, but I know we need pediatricians too, is that this is actually your own national AAP mental health competencies. These are their recommendations from your body saying that we need primary care to sort of be invested and do these things, but obviously you need our help too, which is why we're talking today. Hopefully I'm convincing you why we need mental health and primary care. Again, the burden of mental health disorders is great. We know that the mind and body are connected. They're not separate from each other. And there's a treatment gap for mental health that's existing and is not going away. Like I said, Even if I were to suddenly get a bunch more child psychiatrists, I still probably wouldn't meet that gap. As a training director, I can tell you that across the country, 50% of child fellowship programs go unfilled every year. So even if I suddenly just had all of those programs get filled, they're not going to meet that need in the next 2, 5, 10 years. And so we are going to need this sort of connection with primary care. We know that it can be a challenge. Often you didn't feel like you got as much training as you would have liked in learning how to do this. So we also understand there's a lot of stigma that both we have ourselves as physicians around mental health, as well as the larger society. But we do know that people with mental health disorders can get better. There are evidence-based treatments that do assist, and we want to help get them involved with that care. And we know that primary care can be one of those key pieces to that puzzle. But we know there's these barriers, there's kryptonite. And we understand, as I said, it's the lack of training. You feel like you have insufficient time, because you do. You're not crazy. I can tell you as a psychiatrist, you do have insufficient time. We know that there's this feeling of lack of knowledge. We also admit that we're not always the best at giving you feedback, which is one of the things that the CPAN model corrects. We know that you don't always get reimbursed well. And we know that there's a lot of things that encompass why children are not doing well that maybe is not about their mental health that can make it a challenge. But we're here to say that those kryptonite barriers for you being a superhero, CPAN can help be that steel box that you lock away the kryptonite from, so that you can still have that abilities to go out and fly and help young people out there that have childhood mental health disorders. Let us help you with your kryptonite is what I'm trying to say. So when I talk about sort of collaborative care, this is a model that sort of looks at the various different ways that you can do collaborative care. I really want us to pay attention to, I'm just talking about quadrant 1, folks. I'm talking about primary care settings, PCP, mild to moderate disorders, just like you treat mild to moderate asthma, mild to moderate eczema, mild to moderate headaches, mild to moderate GI complaints. You know, again, my dad is a family practice physician, and I grew up, if I hadn't been a child psychiatrist, I would have been a family physician. The relationships that you develop with your kids and their families is so special and so unique. You help them along their journey, and we would love for you to help them along a journey if what they're also suffering from is a mental health disorder. So if some of you feel like you want to branch out and do some of the more complicated, moderate to severe occasionally, that's great. But what I'm trying to tell you today with CPAN is that's not what we're asking you to do. We want you to call us and refer to us for those kids that are much more severe. That's what I did my training in. But what we want to do is really focus on that quadrant 1 primary care, you helping in that sort of vein of mild to moderate. So if anything else, this slide, what I'm trying to get you to understand, it's mild to moderate that I would like to sort of help your skill and comfort level grow with CPAN. So the collaborative care model really has this feature of sort of working together, and it could be in lots of different settings and places. But what we're doing here specifically in Texas is we're not integrating into your particular setting. And you may actually have therapists in your setting, and some of you I know have co-located psychiatrists, but co-location does not always mean access. And so that's why the Child Psychiatry Network would be helpful, even if you have people that sit in your office, because they're probably busy seeing patients when you have a question. So you can use our access network no matter what. But what I also want to tell you is this is not a novel experimental concept. This has been working in several states across the country. Massachusetts has the longest standing state program with over 17 years, a track record that's very solid. I have here their website. You can go and peruse it in the future to see kind of where we're going to be going when it comes to building out our own website. But what I can tell you is that our CPAN network is modeled very closely after MCPAP because of how successful it is. So this is not an experimental idea. This is something that is proven to work, and we're so excited that Texas has sort of decided that they want to get in the game and really help children with mental health, but we need to do that in a collaborative way. So we need you guys to enroll and sort of participate. So when you look at some research around using these kinds of networks, I have 2 articles here that you can go and look at your leisure again. I'm only going to give you some of the highlights around these 2 articles, but one is about what is the PCP, think about using the support system. And then the second article is about what is the parent's experience knowing that their PCP is using this support. So basically what we have discovered when you ask the primary care doctors, they do believe that having this program allows them to have an enhanced ability to deliver mental health care that is consistent with the family's preferences. Now, we all know how important family and patient-centered care has become, and we know that you know your families well. And so this ability to call up, speak to a consultant, have an educational consultation really does feel that the PCPs who use it says, yes, it enhances my ability. The second thing is that they actually do agree that they learn. And so that what they learn in that one call about ADHD, then they can apply to another young family, and maybe they don't need to call for that, but what they do over time is their questions get more challenging because they start to feel a comfort, and then they start to think, you know what, I can handle this case with the help of the CPAN network. So they do take the knowledge they learned in case one and apply it to future subsequent cases, was what we hope for. The one thing that's still kind of an outlier that we want to work on here in Texas is that there is still a group of pediatricians, even in Massachusetts, who, even though they've enrolled in the program, never call it. Or if they call it, they only call to get a resource. And what we really want to help PCPs notice is back to that sort of suicide as a second leading cause of death. We can't always wait on that referral. Maybe even if you're just a bridge to that ongoing specialty care, but if you at least start the process with help, then I think we can really move the needle. So I really am empowering and encouraging you, even if you're sitting here thinking, oh, Dr. Williams, that's great, but I'm never going to call. That's who I'm talking to right now. We want you to call. We want to show you that this can help the kids that you're working with and help you feel more comfortable and confident and be that superhero that we need. When you talk to parents, the parents actually rate their primary care doctors as better because they called. They appreciate you knowing that you have asked an expert about what to do. So it does not at all diminish your role. It actually enhances your role and strengthens your relationship with your patients by and large when they know that you're calling. And we are more than happy for you to share with your families before you call us that you are going to call and ask for some expert advice. So hopefully this will lay to ease any doubts you have that this is a program that works, that PCPs find very helpful, and that families also appreciate and find helpful that their pediatricians are involved in that process. So Texas. Texas has what we call the Child Psychiatry Access Network. As you can see here on the screen, we're broken up into 12 regional hubs. That actually corresponds with the 12 departments of psychiatry that sit in the Texas Child Mental Health Care Consortium. Each of these hubs has a region of Texas. So this is important because right now I'm speaking to a lot of residents and fellows, and there will be probably a point where definitely a point where you're going to graduate, and you may move out of Houston and you may move somewhere else in Texas. You should rest assured that no matter where in Texas you decide to practice, you can always call the number and you could speak to the hub that sort of corresponds with that region of Texas. So this is a statewide network that we're standing up, and we want to make sure that each of those hubs is reaching out and organizing and enrolling the PCPs in their area. All PCPs in Texas are being invited as we speak to enroll in the network. That includes pediatricians such as yourself, family physicians, PAs, and NPs. There is never going to be a cost for you as a primary care provider or your patients to use the network. That is the reason for why it's in general revenue funding, is that it's meant to be a service that is accessible to all primary care physicians around the patients that they treat. When we ask for enrollment of PCPs, we have an ability to enroll a large group practice relatively easily. Or if you're a small solo practice, we can enroll you pretty quickly with just your solo practice. But we do ask for some demographics when we enroll you: your name, your phone number, your email, your fax, the clinic location. And this is actually to protect your patient's confidentiality. And this is particularly because if you call us back about a patient a second or third time, we want to make sure that we're actually talking to the right persons, because we don't want to share any health information with somebody that we really shouldn't be sharing health information. So we enroll you mostly to make sure that future calls go well. And also if you call us back, about the same patient, we can continue on where we left off with your previous call. So that is the purpose. But we also, for these big practices, have the ability to do a group enrollment so that it's hopefully, it's actually not very painful at all. As I said, you can enroll before you call us or on that first call. And what we also want to recognize is that you have educational needs that might be outside of the phone call itself. So each of the regional hubs will be offering additional educational activities that will be outside the call. We're going to work on doing some ECHO team-based learning projects. We've already done some webinars and we'll continue to do more webinars. We are building out that website that I told you about. It's under construction. And as it gets built out, we'll be adding best practice algorithms, those videos of the webinars, all the things that could be at your fingertips if you wanted to do something real quick and maybe not call us. We'll be having that on the website. So again, we're going to be doing more things than just when you call us to help you kind of improve your knowledge when it comes to child mental health. We like to say that even though it's one phone call in one team, it's 3 services. So when you call the network, you can have one of 3 things happen, and all 3 things can happen at the same time, or they can happen based on what you say your need is for that day. First thing we can do is help you with resource and referral assistance. So let's say that you know for a fact that the child has autism and you want to try to help them get some additional resources. And so you can call our team, give us some information about what's going on with the young person. Our team will do some research and then come back and give you some information about hopefully some good referrals, some good resources. So you can see that we're actually helping you provide some care coordination. So even if you have that in your office, you may not have people that are especially versed in mental health resources, but you may actually not have somebody in your office that can help. And this is why the Access Network is going to help you with that piece of things. The second piece is around behavioral planning. And this is particularly useful. Let's say you have a family, the child is anxious, but the family is very adamant that they don't want to take any medications, but you are stuck and you would like to give them some advice, some ways to kind of help manage the anxiety, but you're not sure what to say or what to do. You can call and speak to our team, and the therapist will help you think through what would be some good strategies that you can help that convey to the family for the family to do. And that could be something you can do in office. And then finally, the sort of, not want to say most important piece, that sounds kind of narcissistic being a child psychiatrist, but one of the biggest pieces that a lot of pediatricians want is the ability to speak to a child psychiatrist in real time. So we looked across the country at the programs that were the most successful when it comes to their networks, and it really what came back to access to the child psychiatrist. So we actually commit to you that we will call you back within 30 minutes if you need to speak to the child psychiatrist. And this allows you to kind of help with, maybe you're not sure what the diagnosis is, maybe you're not sure what questions to ask, maybe you do know the diagnosis and you've tried something but it's not working and you want some help deciding what to do next. You can use the child psychiatrist for all those reasons and more. So the point I'm saying here is that one phone call can actually help meet a lot of your needs when it comes to child mental health in your region. So this program is Monday through Friday, 8 to 5 p.m., excluding Baylor holidays, actually all the holidays that were across the HRIs because we're academic centers. But if it's a holiday, then no, the phone line won't be turned on. We do commit, it's a state metric, that we will answer your phone call within 5 minutes or less for that first phone call. When you do that phone call, you will be triaged. At that triage call, they will ask you some elements of the patient history. You don't have to say any of those things if you don't feel comfortable, if the family doesn't feel comfortable. But if you give us your clinic MRN and nothing else, then we can track that kid so the next time you call us back, we can go easily back to that record. And an MRN by itself is not PHI. So we are able to use your own MRN to help locate the patient quickly if for whatever reason you or the family prefer not to give out PHI. And as I said, we can provide all these resources for you when it comes to the call. And one of the things I also really want to talk to you about the call is, I think we've had a little bit of confusion with some of the primary care doctors out there, is this idea that you have to have a patient in office. Well, I'm too busy, I'm moving from patient to patient, I really don't have time to call. It sounds like a good idea, but never mind. Well, you don't have to call us just when patient is in the office. I know that your in baskets for Epic are generally pretty full, And so you're getting a lot of messages from MBAC, from your nursing, my chart messages from a patient. So let's say in office, you're finishing up notes, you're seeing a my chart message from a family, it's about something related to mental health, and you're thinking to yourself, I'm not really sure what to say to this family. Well, you can call us right then. So the patient doesn't actually have to be in office for you to call us. It really is this idea that you need help with sort of deciding what to do, or you need resources, and then it's a reason for us to pick up the phone and give us a call. We're really kind of here to help you, from top to bottom when it comes to providing this service. So I really think that what we're hoping to do in the next sort of bit of time is really encourage enrollment, encourage engagement, because we do think that this is a collaborative care model that works and is effective, and we want to have this ability to help kids across the state of Texas. So this is why we're talking today. So I'm a teacher by trade. I do occasionally a reasonably good job with it, but we all know this idea that if you want to do something new, sometimes you're a little bit hesitant, you're a little not sure about that you want to do it, do you not want to do it. So what I thought we could do today is actually practice. And so the old tenet, I'm thinking about my dad here when I say this: see one, do one, teach one. Well, today we're going to see one and do one on this presentation. So this is the first tenet of learning, is to practice. So when we do this audience participation piece, I will ask for the pediatrician who's going to call the line to not use their real phone number, real address, and to not use any real patient information, because this is being recorded. But we actually are going to go ahead and give it a whirl and call the phone number right now and see how it goes. So I'm looking to see if there's anybody who'd like to participate. And I think somebody's raised their hand. They're not shy. They're like, yeah, I'm going to do it, Dr. Williams. It's easy and painless. We're going to show you how easy and painless it is. So thank you, Dr. Tatum, for agreeing to do that. So what I'm going to do right now is just mute myself, and then Dr. Tatum, go ahead and call the phone number.
All right, calling now. Hello. Sorry, I'm not getting an answer right now. I'll hang up and call back.
Victoria, you're muted. Well, usually we practiced this the other day and it worked really beautifully. So of course, technical difficulties can make it a challenge. Tracy, do you think that your line will work if you unmute yourself, Tracy?
Dr. Williams?
Yep, I can hear you now, Victoria. Sorry for that small technical difficulty. Go ahead.
Thank you for calling the Central CPAN Hub. May I have the zip code you're calling from, please?
77030.
Great. We're your regional hub here at BCM. How may we help you today?
Yes, I would like to speak with a child psychiatrist, please.
Okay. And may I gather some quick pieces of information? It'll be no more than 5 minutes to get you over to a psychiatrist. Will that be okay?
Yes, thank you.
All right. May I have your first and last name, please?
My name is Andrea Tatum.
Okay. And may I have the clinic in which you're calling from?
Texas General Pediatric Clinic.
Wonderful. May I have a phone number and email address for you?
Yes, it's 713-555-1212. And email address will be pedsclinic@texaschildrens.org.
Awesome. Thank you. And have you called regarding this patient before?
No, this is the first time.
Okay, great. May I have the gender of the patient you're calling about?
It's a female.
Okay. And may I have the date of birth?
It is 10/24/2012.
Okay. 10/24/2012. And would you like to provide an MRN or patient record number?
Yes, the MRN is 00235567.
Great. And can you tell me what are the presenting concerns for this patient?
Suicidal ideation with depression and anxiety.
Okay. And is this patient currently safe?
Yes, they are.
Okay. Is there any medications being prescribed for this patient that you would like the psychiatrist to know about?
Yes, the patient is currently on Prozac, and I think that we may need to switch it to something else, and that's one of the big questions I have.
Okay, great. I will get you right over to the child psychiatrist. Thank you again for your call.
Thank you.
So wonderful. So let me introduce myself real quick. So my name is Dr. Chu, Lawrence Chu. I'm one of the child psychiatrists on the Child Psychiatry Access Network. So after Victoria is done collecting all her information from Dr. Tatum or another pediatrician, what she usually does is she'll either text me or she'll call me and she'll give me a handoff. And then what I do is I log on to Trait, which is our online cloud-based platform where we store all the consult information over there. And that has all the callback numbers for the pediatricians, and I'll give a pediatrician a call back within, usually for me right now, probably within 5 minutes or so. And so, Dr. Tatum, we can do a little practice run if you want. And so I'm just going to go ahead and pretend that I've already called you or I've already dialed the phone, and we can get started from there if that's okay with you.
That's fine.
Okay, wonderful. So good morning, Dr. Tatum. How are you?
I'm doing well. How are you, Dr. Chu?
I'm doing good. Thank you for asking. So let me introduce myself real quick. So my name is Lawrence Chu, and I'm one of the child psychiatrists with the Child Psychiatry Access Network. Before we get started, Dr. Tatum, just wanted to ask you, how much time do you have today to discuss this 7-year-old female with some suicidal thoughts and depression?
Right now, I have about 30 minutes.
About 30 minutes. Okay, wonderful. Well, I'm going to do my best to try to help you out with this patient. So let me go ahead and ask you, Dr. Tatum, how can I help you today?
Yes, so I have this patient. She has a history of suicidal ideation with no active suicidal ideations at this time, but we've been treating her. She also has depression and anxiety. We've been treating her with Prozac, and I'm kind of maxed out on my dose of what I can use for her age, and I need some help because I think I may need to switch to something else, and I'm worried with the comorbidities that I don't want to cause any more harm to the patient, so I need some help.
Okay, sure. And Dr. Tatum, what are some of these comorbidities that you're concerned about with this patient?
She has some aggressive behaviors as well, and I'm worried that, changing around the medicines too much may activate some of those behaviors.
So we're concerned about some of the activating symptoms of some of these SSRIs then.
Yes.
Okay, wonderful. Has she tried any other SSRIs or any other antidepressant, anti-anxiety medications before?
No, this is the only one she's ever tried. Her mom said that she took Prozac before, which was, one of the reasons that we tried that, and it worked well for her. But okay. I think that this child is a little bit different from her mother.
Sure. In what way is she a little bit different from mom?
Well, one, she's younger. Mom just had depression. She really didn't have the anxiety or the aggressive behaviors as well. And so mom just had major depression, and that was it. But with this child, it's a little concerning because it's more to it than that.
Okay. And so in other words, mom pretty much had just a unipolar depression without anxiety, but this child has both anxiety and depression.
Yes.
Okay. Well, great. I appreciate the call. The good thing is a lot of our medications, actually the SSRIs are first line treatment for both anxiety and depression. And so even if we don't use a medication like Prozac and we switch to a different SSRI or a different antidepressant medication, we're going to be hitting both depression and anxiety symptoms at the same time. Now, can I ask you, how long has she been on Prozac for?
She's been on Prozac now for about 6 months. And again, I increased after the first 6 weeks, and I increased again 2 months ago. But again, I'm maxed out for her age. So.
Okay. So she may be close to the max range already. Has she had any really weird side effects or anything like that on the Prozac so far?
No side Well, the only thing I've seen is the increase in the aggressive behavior since we started the Prozac.
Okay, so increase in aggressive behaviors, but otherwise she's been tolerating the medication okay.
Yes.
Okay, wonderful. So yeah, that's a really good question that you ask. Oftentimes when kids have tried one SSRI and let's say they develop intolerable side effects or the medication is just ineffective, we could consider switching to a different SSRI. Have you ever considered starting a medication called Lexapro on her before?
No, I didn't consider it. I was a little bit more worried that I may have needed a mood stabilizer with her aggressive behaviors. And so that was why I was like, let me call and get some help.
Sure, yeah, no, absolutely. And these aggressive behaviors, Dr. Tatum, I didn't ask you in the beginning, but what are these aggressive behaviors usually in the context of?
Anytime. Before we got the Prozac, it would just be whenever someone said no to her or she got upset. Now it's just coming out of nowhere.
Ah, I see. So
and I'm worried that she's a danger, not only to herself, but to others.
Sure. And so it sounds like at one point, a lot of these aggressive behaviors were in the context of being disciplined or being told to do something she didn't want to do. But it sounds like more or less recently it's kind of progressed to the point where she's almost always sort of aggressive to a certain extent. Would you consider that to be her to be a little bit more irritable than usual?
She's definitely more irritable.
Okay. And so, oftentimes in kids her age, irritability may be the first sign of depression or maybe persistent depression that hasn't been adequately treated. So I'm hoping, if we consider switching from Prozac to a different medication, that some of the irritability, some of the depression will get better. Now, certainly with a medication like Prozac, which tends to be a little bit more activating than some of our other SSRIs, it could increase some irritability. It could increase some of those aggressive symptoms that you described. But, hopefully if we switch to a different medication, those sort of symptoms, I'm hoping she doesn't endorse.
Is there something we can do in the meantime while we're switching to help with some of these aggressive behaviors?
Yes, besides psychotropic medications?
Yes.
Yeah. And so what I can do is, mainstay treatment for both anxiety and depression would probably entail both medications and therapy. And so what I can do is I could reach out to one of my colleagues and try to see if we could provide some resources for therapy, if that's something that y'all would be interested in.
Definitely. I think that would definitely be helpful.
Absolutely. Wonderful. So I can certainly reach out to Victoria and see what we can do there. In the meantime, if we do decide to start a medication like Lexapro, at least for me, usually if I prescribe a different medication, I usually start low and I go up slow. And so with Prozac, if you wanted to, we could either take it down slowly, or we can kind of cross taper both of those together. What do you think you'd like to do, Dr. Tatum?
I would like to cross taper because I'm worried if we take her down too low, too fast, without anything else to cover it, that things will get worse.
Yeah, absolutely. And so let's assume that she's on 60 milligrams of Prozac. What we can do is we can go ahead and decrease it from 60 to like 40 for about a week. And when we start her on the 40 milligrams, we can go ahead and start a medication like Lexapro, and we'll just start off at 5 milligrams. And then after another week, we can decrease the Lexapro again we can decrease the Prozac again to 20, and then we can discontinue it altogether.
Okay, that sounds great.
Okay, wonderful. Now, can I ask you, Dr. Tatum, I think you mentioned this earlier, any current suicidality, any other safety concerns otherwise?
Not right now, not at this moment, but I follow with her closely just to make sure that I'm supporting her as well as her mother.
Wonderful. And now, is there anything else that you feel is really, really important that you want to talk about? Anything else that you think I can help you with today?
No, you've been a great help today. Thank you so much.
Yeah, absolutely. And as always, feel free to call us if you have any other questions, and we'd be happy to help you guys.
Thank you so much.
Absolutely. Thank you.
Thank you. I really appreciate Dr. Tatum agreeing to help us kind of showcase. Sorry for the little initial technical bobble. So this is basically what will happen is you'll call the line. Everybody can hear me? Okay, for a minute I said, you'll call the line, you'll get to, and again, if the operator doesn't answer right away, you'll leave your information. They'll call you back within 5 minutes. You'll be asked a few questions about who you are, where your practice location is. If you've already enrolled, it'll just be a quick verification of the information you've already shared. Then the person will ask you some information about what sort of is your need today. And then they will either transfer you to the person that can help you or help you themselves, because Victoria is a therapist. And so who we have answering our phone are people that can actually help with both the resources and the therapy needs as far as behavioral plans, if that's what you're looking for. And then finally, if what you need is to speak to that child psychiatrist, then Victoria and our team, other team members, will transfer that over, do a handoff so that Dr. Chu and our other psychiatrists know what is the question that you're asking, and they'll call you back and provide you with some assistance. We want to be really clear that we want to fit this into your day. So we often will ask you, how much time do you have? Because depending on how much time you have, we may need to sort of condense our questions and comments. But if, for example, Dr. Tam said she had 30 minutes, then her and Dr. Chu certainly could have talked a bit longer. But today with the practice, we were trying to, I think, be as concise as possible. I think the other thing that's really important that Dr. Chu shared is that we're happy for you to call us back every step of the way. So let's say with this case where you're doing a cross taper, you can call us every single time the kid comes in, and sort of just to, if you need a sounding board, somebody to sort of, yeah, this is still working the way we were all planning, or no, something seems to be kind of going off. So it's not a one and done. You can call us back, and you can even know what the schedule is. So if you wanted to talk to Dr. Chu again, then you would make sure that I'm going to call on Fridays, because I know that's when Lawrence is on, and I've spoken to him and he knows this case, and so I wanted to speak to him again. So this is certainly something that you can do when it comes to the network. So I really do appreciate Victoria, Dr. Chu, Dr. Tatum for agreeing to be guinea pigs. Hopefully you got a good sense that this is not something that's super time consuming, difficult. And again, although we were practicing today, we will guarantee that you will get a call back within 5 minutes with your first phone call, and within 30 minutes if you need to speak to the child psychiatrist. So I just want to say thank you. And I'm actually asking people to open their phone, get distracted, don't completely look at me, because I would love for you to join our Facebook page, join our LinkedIn page. Both Facebook and LinkedIn, we send out 2 to 3 times per week information related to mental health. So from our perspective, it's just a good way for you to maybe get little snippets of mental health information. So please, please, please go and join our Facebook page and our LinkedIn page. And then again, if you don't want to go back and watch this for an entire hour, who would possibly? We actually made a 3-minute version of this talk. We really condensed it down, and it's on YouTube with this link. You can also find the link to this YouTube video if you just go to that Consortium webpage that I talked about at the very beginning. So I'm going to stop now and sort of open our team and myself up to questions.
Excellent. Thank you very much for that, that very informative talk, Dr. Williams. There were some questions throughout the presentation that your team was trying to answer. I do want to note, though, that the chatted answers that they tried to send only went to the panelists, so the attendees couldn't see them. So I don't know if they want to rechat them. If not, we can talk about the questions. The first one was about, is this availability of it to community PCPs, or is it only an EPIC? And it seems like the answer was it's available to any PCP in the state. There was a clarifying question. Subspecialists are in the audience, and they were asking if they could call in or not. I was wondering if you could address that.
Yeah, so subspecialists, it's definitely a tricky point. If we really, this is focused on primary care physicians. But sometimes we know that specialists become kind of management because of how complex the challenge is. So I would ask yourself to kind of think, do I really think that I'm primarily kind of the primary point person for this family and this kid, that I would say you could adopt yourself as primary care. But if you're really is a primary care doctor that's working with the young person, then I would maybe more encourage you to talk with that individual for them to make a phone call to us.
One of the other questions was about if there was help with medication, which I think our example showed, but is maybe the broader question then is what are the what services are available in terms of access for help, and how often can you seek that help?
So you can call every day if you want. You can call as many times as you'd like. So again, we want to provide education. So one of the things that Dr. Chu and our psychiatrists would do, in addition to just answering that direct question, is try to do a little bit of teaching. Again, it's going to depend on how much time you say you have. If you just have 5 minutes, we're going to kind of get down to brass tacks. If you say you have a bit more time, then we're going to kind of help you kind of think about the question that you posed a bit more broadly to help enhance your learning. But when it comes to sort of management, our team can help you think through, well, I think this child might be depressed. What questions might I ask to really differentiate between just normal stress with COVID, because we're all stressed out with COVID, for example, or no, this person truly is crossed the threshold over into maladaptive in a persistent enough way that it's a mental health challenge. And then kind of walk you through what to do, talk to you about side effects, recommend labs if that's what's needed based on sort of treatment options and recommendations. So you really can think of it as a phone a friend as many times as you need to help you feel that you have the knowledge that you need to have in order to talk with a family and help make shared decisions about what to do next.
Excellent. The next question asks for clarification. Is there a specific age range of the patients that the services are available for?
I would definitely say that if you call us about somebody under the age of 3, we'll probably be like a little bit less, and we'll still try to help you, because certainly we know that autism and concerns around autism can in particular spark our intellectual disability. But we kind of sort of think about really the age range that you see in your primary care practice up to the age of like 24. So we kind of think that if the kid is still coming to you because they're in college, but they still come back to have their primary care with you, then that's fine. But once somebody's kind of maybe graduated out of the house, hopefully they're not coming to you as a pediatrician, then that's what we would say naturally the service wouldn't be available. We obviously know that some young people and who become young adults have sort of congenital challenges that mean that they're going to be under the care of their family for a long time. And I think that we would certainly be open to talking to you if you have somebody that's older than that, but sort of chronologically older, but intellectually not older, and you were still kind of looking for some help.
Excellent. Thank you for that response. Piggybacking off the kind of subspecialty question, there's been a question about emergency department visits, and some of our physicians that work in the emergency room are wondering, is this a service that they should be looking to use, or can you give some recommendations about that?
So it's definitely a sad thing that I have to say no to this fact. This is meant to be for primary care. And I think the biggest reason for why it's meant to be primary care is honestly this idea that you're going to have continuity with the family. And so it's not that you're seeing them one time in an ER and then never seeing them again. So I think that the state and all the programs, most of the programs across the country are really focused on that primary care sort of team. But I wouldn't mind the emergency room physicians maybe sort of saying something about CPAN and encouraging the families to maybe talk to their primary care doctor about it. Because again, that's another way for families to be aware of it. The families cannot call themselves. We've had a few families get confused and call the line, and we gently redirect them back to their primary care doctor. So this is not for families to call, but if the family wanted to encourage their primary care doctor, that would be fine.
Excellent. And there was an earlier question about promotional materials. Is there any that you would have available for people to distribute? Should they use websites?
So we do have some promotional materials. So again, we're working to enroll primary care doctors in our hub. And everybody theoretically on this call today is in our hub. So if you want to reach out to me via my Baylor email address, which I badly enough did not stick up on here, that was my fault, but you look me up, Laurel Williams in the Baylor, you'll find me. But if you have not actually gotten a contact from us yet, then I want to know about that. And so does Victoria and Tracy, because we want to reach out to you and provide you with the information that you're talking about and actually help you enroll. Please reach out. But yes, we do have some informatics that we can share when we're enrolling.
There's a question about helping assist with transition to adult providers / resources?
Sure. Absolutely. So again, if you call in a referral and you know this young person's about ready to kind of graduate from your care, but does need ongoing care, then that's a good reason to call us, and we can kind of help you think through. And our goal with the resources, so sometimes a resource, they're not going to call you back right away, because as we all are aware, sometimes it's hard to find a resource. So again, they're going to ask some information, particularly around insurance status, so that when they go do a research, that they hopefully can give you and the family, hopefully at least one choice, maybe more than one, that's a warm handoff that actually has an actual chance of it working.
I think this one comes from our residents. This is a good one to end on since we're almost out of time. With such a pinch for child psychiatrists, should general pediatric training programs be looking to provide more training and guidance in that area?
Yes, and again, the one thing that's great about Baylor Peds is the team at the top really wants their pediatrician residents and fellows to learn mental health. So I know we have a good partnership with our Baylor Peds team. There's just a lot of constraints sometimes, and it goes back to there's 30 plus pediatric residents per year. We have a large program. Baylor is considered a large program. I have 8 per year. So we start trying to figure out how to put enough rotations in play. It becomes difficult. So one of the things we actually have done is reached out to the Baylor Peds residency team to get all the fellows and residents in their continuity clinics hooked up to CPAN, so they can start practicing even in residency using the number and using the consultative service.
Excellent. Well, we are out of time, so thank you very much for this very informative talk, Dr. Williams, and hopefully people will find this a helpful resource. I know I would if I was still practicing in the community. I'm in the ICU, so don't get to take advantage of it, but sounds like it's a fantastic resource for those people that need it.
Thank you so much for agreeing to let our team participate. I really appreciate it.
All right, everyone, have a great week. We'll see you back next Friday. And please reach out, like Dr. Williams said, if you have any interest or additional questions. Thank you.